Hey, good evening, everyone. Thank you for joining Research Task Force Acupuncture Cost Effectiveness webinar. Yair, would you like to start saying some words on behalf of ETCMA?
Sure, thank you, Gil. So first of all, welcome all. It's a research webinar, but all look so serious. And I want to first thank you, Gil, and all the research task force for the amazing work you are doing and also in preparing this webinar. People usually don't know, but it takes many hours to prepare a 1-hour webinar. So thank you for your hard work. I just want to say one thing. One of our main aims, is to make Chinese medicine integrated into healthcare, be fully recognized by insurance. In the same way that, let's say, Western medicine, definitely physiotherapy and psychotherapy and other forms of medicine are recognized. And there is one major thing about world health, Western world health. The cost of health is going up dramatically every year. For one cancer patient, for example, it's the same cost than to keep sometimes few thousand or 50,000 people to maintain their cost. And we are going to face a dramatic, I think, difficulties in the next coming years as far as the cost of health. What we are offering is a low cost effective medicine. And whenever I'm meeting people that are health decision makers, either from government or from hospitals, this is usually the first thing I'm saying about our medicine. I'm saying two things. One, we are low cost effective medicine. The second, we are evidence-based medicine. And these two huge and main topics are, I think, extremely well handled by the research task force. And today's webinar, into showing the savings we already can show the evidence of reducing cost of medicine. It's, I think, one of the extremely important factors in creating change in the future. And it is, I think, a major, not just concern of the health system, but also of humans, to have an efficient, low-cost medicine. And this is what we are. So with all this introduction, I'm looking forward to hear the research task force and their findings and evidence that they could draw to make this statement more solid. So thank you all for joining, and thank you, Gil, and all the task force. Thank you very much.
Thank you, Yair, for your inspiring words and for the introduction. First, I will share my screen. Can you see my screen?
Yes.
Okay, great. So first, I would like to thank all of you, the participants who come from many different areas and time zones. Your attendance and support are very much important to us. My name is Gil Ton, and before we start, first I would like to introduce our team, the Research Task Force, and I want to introduce our aims, objectives. Also, I would like to tell you that this webinar is recorded and will be available in the ETCMA YouTube channel. And as well, all the content of this webinar will also be available to you and our members, ETCMA members. So you can download the information and use it to advocate our profession. It's for your use. Quickly, I want to introduce the RTF and our aims. So we are a small group working together the last year and a half. All of us are quite motivated to provide relevant and high quality research materials and also tools for you in order to inform our members about acupuncture research, and not only informing you guys about high quality research, but also how to use it. We also want to assist each one of you to become a better researcher by basically submitting well-written case reports and interesting case reports to enlarge our clinical-based database. One of our first projects, our first webinar last year was about case reporting. So this information is available, you can download it. And if you have interesting cases in the clinic, try to write them down very well and submit it to us, we can help you. Our team is basically, we are a group of 5 people. More people will be joining us. We have in the south of Europe, Aram Akopian. In the north part, from the Nordic region, we have Anya, founder. From the UK, we have Mark Bowie. And from the Netherlands, we have John Jalsfield and myself, Gilton. So what we do is quarterly newsletters and webinars. The newsletters and the webinar are in the same topic. In 2022, we had pain webinar, case reporting, coronary heart disease, and stroke. And for this year, in 2023, we are starting with the acupuncture cost effectiveness. And we'll have 2 treatment modalities related topics, which include moxibustion and low-level laser therapy or laser acupuncture therapy, and 2 condition-related research topics, which will be gynecology and digestive disorders. So stay tuned, keep coming to our webinars and support us by your attendance, and use our materials and share it with your colleagues. Today, my presentation will be about the cost effectiveness of acupuncture treatment in migraine patients. It is a nationwide cohort study coming from Taiwan. Outline for today's presentation, obviously, the presentation is short. It's about 10 minutes, so it will be very limited. I will try to highlight the key findings and the study findings from this paper, and we'll talk a bit about observational studies and the term real-world evidence. So this publication comes from Medicine Journal. It was published in 2020, and wait, I need my laser. I forgot to turn on the laser. Can you see my laser now? No, you cannot see it. Well, never mind. So these publications come from Taiwan. The first author, Dr. Tsai, is a colleague of mine. We did together a PhD in the Graduate Institute of Acupuncture Science. Dr. Tsai is a neurologist, and he did his PhD in acupuncture science, and he sees a lot of migraine cases in his clinic, in the hospital, in the outpatient department in China Medical University as hospital. Okay, and he was interested to investigate the medical expenditure in acupuncture use in migraine patients. So observational studies, in short, basically cohort studies. Observational studies, it's a type of cohort studies. They observe large group of individuals and evaluate certain risk factors or association between diseases. So very simple explanation, we want to evaluate the risk factor of patients who smoke, who use cigarettes, and its association to lung cancer, for example. So we take a cohort group of exposed patients who smoke regularly, and we take a large group of patients who do not smoke. And then we want to measure the outcome, how many of them develop lung cancer, how many didn't develop lung cancer. And then we do some statistical analysis and we compare the two cohorts. This is basically what it means, observational study. In terms of the pyramid of evidence, just a sec, something here is bothering me. In terms of the pyramid of evidence, the observational studies, cohort studies, are ranked quite high in the pyramid of evidence. They are on the third at the top of the list. However, in order to claim causality, we still need randomized controlled trials or systematic reviews or meta-analysis of randomized controlled trials. However, observational studies can provide us good information and evidence to support association between diseases, and also valuable information for health policy decisions. And observational studies are basically a big part of the term real-world evidence in medicine. And basically it means that we are obtaining real-world data, which is observed. It was observational data obtained outside of the context of randomized controlled trials to generate, and it's generated during routine clinical practice. So it basically represents some kind of our regular clinical practice in the clinic. And Taiwan's national health insurance is a great example for this kind of real-world data. Okay, Taiwan has a mandatory national health insurance program, and basically 99% of the populations are being covered. All the population in Taiwan is being covered, and the NHI has databases, contains registration files and original claim data for reimbursement. Okay, so in order to reimburse the patient from the cost, they have large databases, but these databases are also being provided to scientists in Taiwan for research purposes, and they help them to generate real-world evidence to support clinical decisions and healthcare policy making. Okay, so let's go back to the study that I introduced. The study flow chart. We want to measure migraine patients who received acupuncture, and we want to evaluate the cost effectiveness if acupuncture can reduce the medical expenditure. Okay, so eligible study subjects were patients with migraine disease code. Okay, all of these observational studies and this type of studies using ICD-11 codes. Okay, so each one of the patients has a disease code, in this case, migraine. So they were diagnosed by a neurologist and had at least 2 outpatient or 1 inpatient visit in order to enroll to the study. The case group was comprised of patients who did acupuncture at least 12 times after they received the migraine diagnosis. And the control group was comprised of patients with regular medical care. Okay, the 2 cohorts were matched by a propensity score of demographic factors, comorbidities, migraine treatments, drugs, and frequency of migraine outpatient visits. So basically, we don't have time to talk about propensity score, statistical method of matching the 2 cohorts, but in a simple language, it means that the 2 cohorts were matched and similar in terms of their demographic factors, comorbidities, their diseases, and their drugs. Okay? And the results. We had this study had at least 2,385 cases, migraine patients, who were part of the final analysis. 477 of them were acupuncture treatment case. So the case group was the acupuncture treatment, and 1,908 patients were the control group. These are the patients who didn't receive acupuncture treatment. About 75% of the patients were female, and the mean age was 44 years in both groups. And there were no significant differences between the two cohorts. And the results, I cannot find my laser pen, unfortunately, but the results, if you can see from the p-value on the right column, the medical expenditure on emergency care and hospitalization were significantly lower in patients who had acupuncture treatment. As well, when the two cohorts were stratified by medication usage, migraine patients with more than one type of drug treatment combined with acupuncture had significant lower frequency of hospitalization and emergency care expenditure within 1 year. So basically what it means that it indicates that a severe migraine patients who use more medications and they got acupuncture, the benefits from the combined treatment was better in terms of economy. So the research conclusion was that acupuncture can reduce the medical expenditure in migraine patients within 1 year after diagnosis, because this study, they followed the patient for 1 year. And for health policymaker, it is cost effective to encourage combining acupuncture and Western medicine to treat migraine patients. And for doctors in routine clinical practice, they should consider to use acupuncture in migraine patients. So thank you for joining. This was my short presentation about acupuncture cost effectiveness, and I will stop sharing my screen now.
First of all, I want to thank everyone who's taken time away from their busy schedule to join us. I want to thank Yair for the introduction and for actually having the vision to initially create this group and see to it even today and actively participate and see its progress and its effectiveness and its growing success. With his leadership and with our new ETCMA executive committee, we hope to be able to do a lot more for all of you. Thank you. And Gil, you know, I've known Gil for quite some time now, and he's a consummate researcher, so I know that the research task force is in good hands. What I'd like to do today is talk a little bit about cost effectiveness of acupuncture for low back pain, a very specific research task force infographic. But I want to talk a little bit differently than my colleagues generally do. Now, you know, what we're not lacking in terms of acupuncture's effectiveness in general is research. There's substantial amount of good empirical data and raw research that is available and is being continually collected and developed by a variety of communities. And some of you present in this room will find yourself very comfortable right here in this scope of things with consummate data packets and p-values and ANOVAs and beta levels, et cetera, et cetera. And these are great for our for the creation addition of empirical data and raw research. What we need more of, I believe, is evidence-backed value statements. It's taking the research statements, just like what Gil was presenting today, and extrapolating that into valuable statements for your stakeholders, for your audiences. And these could range from your average layman to potential patients to potential collaborators, MDs, other professionals in the healthcare field, even litigators and lawmakers, government agencies who are involved actively in regulating and or establishing the rules for our profession. And that's where I think applied research really comes in. And this is a term that I want the research task force to primarily focus on going forward. And with the help of the extremely good research members and new fresh ones that are going to be joining us, joining our team soon, we hope to be able to produce more of these research infographics and very sharp, clearly defined, evidence-backed value statements for our members, for you to use in your clinical practice and in your businesses. To that end, what I'd like to do is introduce a very simple hypothesis that is ready for testing right now, and that deals with specific cost effectiveness, right? We call it journey to wellness or journey to relief. Now, according to the cost of low back pain results from a national register study in Sweden, the average cost for an acute uncomplicated low back pain is averaging 2,753 euros from time of chief complaint initial recognition to seeing relief. Now, this excludes any complications and or invasive therapies such as surgical therapies, because that could really balloon the cost up. And if you look at comparatively what a typical course of treatment for a uncomplicated, unspecified low back pain costs for a typical 8-session visit, you're looking at about a third of cost to the total comparison of the cost of seeing the relief. So what we'd like to do from the research task force is potentially put together a social study. This won't be a clinical study, but a social study with multiple centers that we could do surveys and collect some raw data to do some fundamental analysis and comparison to test this hypothesis. So if you're interested, reach out to Gil and see if we can put together a group of you to collect the data and put together a postulate to see if we can test this hypothesis going forward. So what I want to do again is talk about how you can take that and leverage it out. Here's a very successful campaign by our colleagues in Australia who took the specific shortage of the general practitioners and the long awaiting times between the appointments or even to see these practitioners and turned it into a relevant business proposition. Get treated while you wait to see your GP, because we have the best value in terms of immediate results in our profession. You know, your average time, as you saw in the previous slide, could vary very lengthy by the time imaging tests and other diagnostic tests are done and evaluated. You're in the meantime in pain, either living on analgesics or NSAIDs or opioids or dealing with coping with pain. Whereas our profession can produce immediate results, first treatment results. You've seen it. I don't need to talk about the effectiveness of our profession. According to the International Association of the Study of Pain, point prevalence for low back pain in 2017, this is quite a while back, was 7.5% of the population of the world. That was about 577 million people. And low back pain, unspecified low back pain, was the leading cause for years lived with disability. And since then, it remains generally a high concern for public health. Interestingly enough, 89 to 95% of people presenting to primary care do not have a very specific, identifiable pathoanatomical association origin for their pain. And over 80% of the total costs attributable to low back pain is due to loss of productivity and disability. Given that fact, in Europe, it's shown that the cost associated with low back pain is anywhere between 0.1 to 2% of GDP of a nation. That's a substantial figure that a lot of your litigators, a lot of government agencies are looking at. How can we make an impact? How can we look at these numbers and reduce them? Well, acupuncture has been shown from a variety of high quality economic analysis in Germany and other countries that there are specific value propositions that you can take. And what I've done is I've extrapolated all of the data out, and the researcher links are available for you in this infographic, which will be available to you for review. And you can go to it anytime if you want to dig deeper. If you're in that left field of the research data and you want to really dig into the p-values and n-values, go for it, have fun. But acupuncture is cost effective for the treatment of low back pain, both alone or combined with usual custom care, right? That was Andoni's 2017. Much more cost effective if there's comorbid depression is included. And fully 90% of people who have low back pain are going to have, especially chronic low back pain, are going to have some emotional, mental, depressive issues, conditions that they're just dealing with. Pain has a tendency to do that, right? Cost effective for low back pain during pregnancy. This is another really interesting statement of fact. So that's the key, is to provide you with evidence-backed statement of facts that you can use in your advertising campaigns, in your marketing campaigns, in your papers for approaching litigators, et cetera, right? More effective, more cost-effective than NSAIDs, Gorosky 2018, and cost-effective for acute as well as chronic low back pain, Sconard in 2022. According to the WHO, the threshold acupuncture complement to standard care for relief of chronic LBP is highly cost-effective. Taylor et al. 2014. US health insurance data showed that the number of physician visits for low back pain decreased 49%, that's about a half, when acupuncture cover was introduced in their coverage, in the insurance coverage. That means that as people began to use acupuncture more proactively, they saw such relief that the usual visits for low back pain to the GPs were drastically reduced. And that overall correspondingly reduced the service cost by 37%. And for insurance companies, these are big numbers, right? They're dealing with, millions of members and millions of coverages, et cetera, et cetera. And in Japan, manual workers with back pain in factory reported less pain, improved mood, reduced number of hospital visits after 8 weeks of acupuncture compared with workers in a control factory, right? So the medical expenses were significantly lower after acupuncture treatments, from 100.1 to 7.3. This is a drastic reduction, I think, in terms of the reduction of the total cost, right? And that was Sawasaki 2008. So these are the research materials that are all associated for them. They're available. You can go back and look at them. The idea of these infographics, and this is just the latest. We now have a pretty good library that we're building of these types of short, concise, evidence-backed infographics that you can use in your clinical setting, in your practice, and in your business planning and association planning. And last, what I'd like to do is, since this is a research topic, I'd like you to introduce again a very unique global project that ETCMA is working on as a collaborator, excuse me, called Acupuncture One Voice. And this is the idea, I think Gil alluded to the fact of coding, because I think diseases, especially with the ICD coding, I don't know if you're aware, but the World Health Organization has completely changed and introduced a whole new traditional medicine specific codes for our profession, for TCM practitioners, for acupuncturists, for you and I. If we do not use those codes, if we do not know how to use them, or at the very least understand how to apply them in our clinical practice, other professions are going to co-opt these and begin to steal our profession away from us. So if you're interested in working in this environment, there's a big evidence research project that is about to launch from the ETCMA and acupuncture1voice.org that offers you the ability to begin the feasibility, to begin the introduction to these codes, and to see how you can look at a Western diagnostic code for, let's say, low back pain, and correlate it into our own professionally done TCM and traditional medicine codes, including channel theories, 8 principles, internal, external, vital substances, even channel pathologies for acupuncture and for TCM. So I want to again thank all of you for participating, for joining the time, and I will conclude my presentation and turn my share away.
Right. So and I'll just say thank you very much, Aram, for your talk, which is packed full of interesting information and ideas. Mine is a brief overview of acupuncture and cost effectiveness, rather than being focused on any particular condition or piece of research. And hold on, let me just, okay, it's better. So economic decision making is at the heart a question of balancing up costs and health benefits. But I have to say right at this point that it's much harder to do this for private practice, because our fees are not related to patient benefit in any very obvious way. I was trying to think when Aaron was talking about kind of waiting time and how patients save waiting time for their back problems coming to acupuncture. But I think it would need a health economist to come up with some clever formula for that. So economic analyses come in a whole array of different sorts. I'm going to just split them very simply into a simpler sort of analysis and a more complex. So here are some examples of simpler ones. And these are on the left, you can see there are two from individual GP practices, and on the right, there's one from a specialist NHS clinic set up to treat people with OA, knee problem awaiting surgery, and they gave them group acupuncture. And you can see that all of these produce cost savings. The acupuncture by applying the acupuncture service. The amount of benefit, the amount of the cost saving varied quite a lot between them. Patients were quite different between them. And what is common for all of them with this sort of model is that if some patients get big improvements through the treatment, then it means that they're able to save on conventional care, whether it's medication, physio, seeing a consultant, or surgery. So the sort of things that Gil was pointing out in his talk. And some of these, particularly surgery, you've got potentially large cost savings. Now, in the more complex sort of economic analysis, and we're talking here about things that are done at state, national level for the whole population. And the benefits in this respect get measured always as health-related quality of life using some kind of standard questionnaire. And these then get converted into something called QALY, quality adjusted life years. This is a kind of special currency that health economists use. So this is it here. It means that you can compare values across diseases and countries. And a QALY tells you how many years of high quality life patients going to get with a particular intervention compared with another one. For example, acupuncture compared with usual care. So in order to work out the QALY, you also need to have make some decision about how many years you're going to say that you're applying the benefits for. And this is an important thing because there's a big difference in the results depending whether you're looking at a short-term thing or a long-term thing. So if you consider just saying that the acupuncture benefits last for, say, a 6-week course of treatment, as compared to saying that they carry on over the months after that, maybe for a year or 2 years, that's a very big difference. And generally, the longer the term horizon, the better it is for acupuncture. There's another big decision to be made around costs. If you take what NICE, the organization that decide on which treatments are going to be taken up by the NHS in the UK, they only include the direct costs of the acupuncture as an add-on for standard treatment or no acupuncture treatment. And so in that case, having an acupuncture service is always going to cost more, okay? But they don't include these other costs, whereas other researchers sometimes include a lot of other costs. So, for example, indirect medical costs. So medical costs are outside the specific interventions that you're looking at. So it might be that the things that we were talking about before, extra medical consultations, going and seeing a physio, having extra medication. And the really big one is if you include the so-called societal costs, i.e. you cost in the lost work days due to the illness. And again, the more of this that you include, generally, acupuncture does much better. And we're going to look now at a couple of examples of this. The first one is from NICE's guideline for chronic pain in the UK, 2021. You remember that they recommended acupuncture for this. So part of that was a cost effectiveness analysis where they compared the acupuncture against no acupuncture. So the benefits come out as 0.041 QALYs. Looks very little, but QALYs quite valuable. The costs, as I said, it's always going to cost more because you're adding in acupuncture. And the cost here comes from them applying sort of NHS standard payment rate against 5 to 6 hours total acupuncture treatment. So you divide one by the other and you get a cost effectiveness figure. But what does that mean? Is that good? Is that bad? £8,500? To know whether it means that acupuncture is cost effective or not, you need to know how much the state will pay for extra benefits. And this is usually worked out in relation to GDP, the gross domestic product of the country. In the UK, the threshold for cost effectiveness is £20,000. So 8.5 is obviously much lower. So yes, acupuncture is cost effective for chronic pain in the UK. Now, the second example is very different. This is from Spain about shoulder pain. You can see for a start that the benefits, 0.11 QALYs, as opposed to 0.041, much bigger. If you look at the graph, this is the change in quality of life for the acupuncture plus exercise group in blue compared to the exercise alone group in red. And you can see the importance of the time horizon, because if you just took it at 2 or 3 months, there's not much difference. But if you look over 12 months, it becomes a massive difference. And the costs per patient, this is an even bigger difference from the NICE analysis, because now they're not coming out as extra costs for providing the acupuncture. It comes out 70% lower, €500 per patient. How does that happen? Well, it happens by the group that had the acupuncture required fewer visits to doctors and physiotherapists. There was also, and this is where the real big money saving came in, much less absenteeism. You can see in that group, 56 days off work total, as opposed to 805 days off. It's an enormous difference. So in this instance, you don't calculate cost effectiveness because there is no cost. You're actually saving money. The acupuncture is beneficial and it saves money. And the technical term for this is acupuncture is dominant. Acupuncture dominates the usual care. And in that instance, logically, you ought to replace the usual care with the acupuncture. There are quite a lot of examples of high quality economic analyses that have been done that show that acupuncture is cost effective. And there's a list of probably most of them here. You can see mostly done in Germany and the UK, but they're starting to be done elsewhere, particularly China more recently. So summing up, acupuncture is not only cost effective for many health conditions, but could also be cost saving. So Aram, if you're looking for a nice, bold statement, takeaway statement for members to use, then something like this is a good one. And on that note, I'm going to finish my talk and say thank you very much for listening. And I'm going to pass you on next to Anya.
Good. So mine is a bit more simple than the previous presentations, because this one is on a very specific condition in pregnant women. It's when they present with a breech version, where the fetus is turning the wrong way at 33 weeks castration. So this is what we're going to take a look at. Hopefully, if I can get, there you go. So breech position is a problem because of why? It's luckily only between 3 to 5% of pregnant women who presents with a breech position. But the problem with this is that they usually have to have a cesarean, which leads to, let me see if I can find my pen here. There it is. The cesarean that leads to a potential complication as well as societal cost. If they do not have a cesarean, or if the women choose to, they can, the midwife or doctor can try and turn the baby by pressuring in a specific way on the abdomen of the woman. It can be quite painful, but it can also help turn the baby. But there's also a lot of different potential complications with this procedure. So this study has investigated on how we can use moxibustion on bladder 67. And one of the reasons why they are taking a look at this is that Acupnucture, as they call it, is considered both safe and non-invasive. And also they found that patients and hospital departments are willing to use complementary modalities if these modalities are considered to be safe, which moxibustion is considered to be. So the aim of this study was to generate information by a decision analytic, sorry for my English today, approach about the projected effectiveness and cost of BVAT. BVAT is moxibustion, compared with the expected management, including associated procedures such as external syphilitic version, in order to reverse breech presentation after the 33rd week of castration and reduce the number of cesarean sections at term. So expected management is just what they usually do. So the model is that they start at 33 weeks of castration, and they are followed by a time path until 1 week after delivery. The presentation is confirmed by an ultrasound at 33 weeks, and all of the birth took place in a hospital, and the pregnant woman and her husband or partner went to an acupuncturist at week 33 and week 34 and received instruction on how to treat with moxibustion at home. So they taught the husband or the partner how to use the moxa stick on the woman at home, and they had daily treatments for a week. And so the analysis, cost effectiveness analysis, the definition of that is an assessment of both the cost and effectiveness associated with different management strategies for a healthcare problem. And the study showed that the percentage of breech presentation at delivery was 32% with the moxibustion, and when they only did expected management, it was almost 53%. So it's much higher when you do what you usually do, and much lower when they gave moxibustion at bladder 67. And here ECV is the pressure on the abdomen when trying to turn the baby. When the pressure on the abdomen was performed, the number or the percentage of breech, on breech presentation was 11.6, and when they did the usual care or the expectant management, the number of breech presentation at delivery was 18.8. So again, acupuncture performed much better than expectant management. The difference was not as high as when they did not try and turn the baby via pressure on the abdomen. So here you can see how many or the percentage of cesarean sections at delivery. When they did nothing, there was 36.6%, which had the moxibustion, who needed a cesarean, and 50.3% who needed a cesarean of the women who had expectant management or usual care. When they tried to turn the baby by pressure on the abdomen, there was in the moxibustion group, there was 23.1% who needed a cesarean section, and 27.8% who needed a cesarean section. And here is the how much it costs in euros, and this is again for the moxibustion group. This is for the expectant management group, and this is again for the moxibustion group and expectant management group. So the conclusion of the study is that the results of this decision analysis suggested that for the rectification of a fetus in breech position, a woman at 33 weeks gestation, moxibustion reduced the number of breech presentations at term, the number of cesarean sections, and was less costly when compared to expectant management, including ECV, which was turning the baby.
Maybe Yair, would you like to mention or share your thoughts about our webinar?
Well, first of all, well done, all of you. I mean, I must say, people don't realize it's not an easy topic. You have to really dig. I mean, most of the cost effective is for complementary medicine and not necessarily acupuncture. So to dig out the acupuncture research worldwide was quite a major task. So one has to understand that it's surprising that even we have the evidence that we have. It's definitely, when things are presented, oh, great, but you don't know how much digging needs to find out and how impressive it is that we already have evidence. And I think, Mark, you correctly spotted what is cost effective. I mean, what you put in and what you don't put, like closing of workmen's days, working days, is a huge benefit. And sometimes it's not included. And again, the cost of acupuncture, you have to weigh it with many other factors in order to come up with a good conclusion. But I think the bottom line is that we have enough potential studies to show the very strong evidence that acupuncture saves money. That's the bottom line. and we are low-cost effective medicine. Obviously, if somebody wants to prove it better, let's see that some research money is going to that direction. Doing research is very expensive and complicated. So as I say, we're lucky to have this amount of research. It's much more than I can tell you expected even by authorities or peer colleagues. The evidence that we saw here are of a very high level. So again, thank you for finding them, for taking the main message out. And I think this webinar should be used by all of you and saved, especially the big bottom lines when people are talking about Chinese medicine. I mean, really, low-cost effective medicine is a very strong statement. Adrian. Go ahead, Adrian. You have to unmute.
Okay, great. Yes, I would very like to also show my gratitude from the advocacy committee, because as you all know, cost effectiveness is really an important issue from the politicians' point of view. So this is also being requested by them. So I'm really happy and would like to thank Jill and the whole research task force for this effort. And I'm also really looking forward to this one pager on this cost effectiveness that can be used then within the European institutions. So I will bring this along, and yes, so thank you again. And especially also I would like to point out this presentation of Mark, like also saying this cost savings, that's really another way of bringing it, and I really liked it, so thanks.
Again, all the participants, thank you so much for joining. All of this information you can find in our newsletter, our Acupuncture Cost Effectiveness newsletter. Basically, what you had today is different research that you may ask yourself, how can we use this as individuals, as practitioners in the clinic? So first of all, it can help to strengthen your confidence that acupuncture is not only a clinical-based effective, but also cost-effective. For example, my research is more like a large-scale nationwide population study coming from Asia, from Taiwan. Anya's study is coming from the Netherlands, from Rotterdam in 2017. It was more like a case control study, observational study. What Mark did was taking summaries, systematic views, and meta-analysis, big, large-scale summaries about different topics of acupuncture cost effectiveness, and Aram's infographics summarizing all up. So all of this information is you can find in our newsletter, and you can download it. For example, if you're interested in headaches and migraines, so the paper I presented, all the citations and the references inside the paper are very much relevant. You can find very good reference list, so you can start. This is a starting point for you guys, and also to start to advocate acupuncture as a cost-effective profession to your patients and to your colleagues, and with everybody that you can share with this information. So again, thank you so much for joining and supporting us. And the webinar is about
See you next time.
end it.
See you next time. Bring in friends. The more the merrier. Okay? More.
So see you next time. Our next webinar will be in June. And the topic will be about moxibustion and research-related content about the use of moxa in our clinic.